I'm Nick Maytom. I'm the director of the acute pain service and also an anaesthetist at Wollongong Hospital. I work in both the public and private sectors, and we run pain services across both public and private sectors as well. Um, at our institution, it was quite common for us to use slow-release opioids up until quite recently, and this was despite the college's position statement advising against this practice. We had rationalized this practice by, maximizing multimodal analgesia and using primarily atypical opioids, believing that we were exercising, a safe clinical practice. So at Wollongong Hospital, we were quite early movers in terms of the uptake of atypical opioids. We were one of the first sites to have access to immediate release tapentadol in our IMPREST, and we had quite a high usage of sublingual buprenorphine or Temgesic, and really dropped our rates of oxycodone consumption relative to other sites. Despite this, we were really slow adopters for the avoidance of prescribing slow-release opioids, which I found interesting. And I thought we were doing the right thing by maximizing our use of atypical preparations for these slow-release prescriptions, with the backing of daily reviews by the acute pain service. And it was really when Jenny Stevens was presenting her most recent data from looking at public and private hospitals in Australia, and the lack of any analgesic benefit with the addition of slow release preparations and the increase in adverse events, that I realized that we should really stop this practice altogether. And we were able to do this with the implementation of the acute pain pathway and the restrictions from the New South Wales statewide formulary. To formalize this process, mainly at the public hospital, we implemented an acute pain pathway or an analgesic pathway. This had the backing of the acute pain service and acted as a guide or template to the junior clinicians in our hospital in terms of giving them a range of opioids to choose from and emphasizing multimodal analgesia and advising against the routine prescribing of slow-release opioids. This pathway has given our clinicians more choice in which immediate release preparations they're able to select from, and they're able to better choose an opioid to suit a certain clinical picture or to suit a patient's certain clinical need. We're more than happy to share our analgesic pathway with other health districts and other hospitals. It offers a sensible guide, I feel, to initiating analgesia in patients in terms of allowing flexibility with dosing and intervals, and catering for the interpatient variability in terms of their response to opioids. As I said, this is a guide, so individual patients will need, that their comorbidities taken into account, but it offers a good framework for junior clinicians to work from and then tailor as needed for certain patients. Looking at our incidence of respiratory depression, we were outliers in the state, and after having implemented the acute pain pathway and minimizing the use of slow-release opioids, we've gotten down to zero over the last few months. So we've made a substantial improvement to the clinical safety of our patients in the hospital, as well as promoting best practice prescribing.